Let me just say that this is our 7th series of open online briefings, and it's our 7th episode in that series. It's altogether our 118th open online briefing from the 4SD team, and it's going to be the last in this series. That means that when we restart again, which we expect to be in January, we'll do something a bit different. And our plan is right now to look and see whether we could perhaps do a more joined up briefing that looks at a number of intersecting issues, particularly those related to the global crisis, the current situation with regard to food systems and food systems transformation, also COVID, but we'll also look at other public health issues. And if all works well, we'll try to use the opportunity to share observations about systems thinking and systems leadership. So that's what we're planning for the next session. We're not quite sure how often we'll do them. And there are many quite tricky issues we have to resolve. More colleagues from 4SD have joined while I've been talking. Twee, Marianne, thank you for being here. I'd also like to greet Christian Lara, hello to you, to Claire Rayner and Richard Longhurst. We're building up. Karen Kaplan, you're here as well. And Zara and Miles Breeding are on too. I can see you both. We're probably going to have more people on, and what I'm quite keen to do is, as before, offer my update of what's happening and then follow that with space for your comments. Hello to Annie and Keith Appleyard, as well as to my daughter, Polly. Now, I've explained to you where I think we're going to go. And the reason why I've done that before we start is that I'm keen that as we have our conversation, then we can also look at the kind of issues we'd like to continue looking at. In our open online briefings until recently, we have been spending quite a lot of time exploring different issues related to COVID-19. And so just before I go in, please note this is recorded, and it's recorded for sharing on the 4SD website. And we'll send a link to the mailing list as we usually do. Obviously, if you do not want anything you say to be made available when the recording is put onto the website, please let Catherine or Mihika know. I will invite Catherine in a bit to make some comments, but I'm just going to talk a little bit myself first. If we just revise a little bit some of the things we've been talking about in these open online briefings, I could offer you some headings. We think we should focus primarily on the virus and see people as the primary response to that virus. Virus is the problem, people is the solution. So when we're talking from 4SD about this pandemic, we're trying to talk about what the virus is up to and the way in which it is impacting on individuals and populations everywhere. So what's happening with this virus? Answer, it is still surging all over the world. And it's surging in a way that is able to cause quite high levels of disease. Right now, there's a cumulative total of 600 million recorded instances of COVID-19 infection and 6 million total deaths of people who are positive with COVID-19 when they die. Now, in the last week, there have been 2.7 million people recorded as having COVID. This is still an enormous number. I spoke to Maria Van Kerkhove of the WHO technical team the other day, and I said, what's the real number? She said, we think it's 5 times as many as are recorded. So if that's true, that's 5 times 2.5, that's 12.5 million cases a week, which is a lot. And so nobody should be under the impression that the pandemic has disappeared. I've asked people not to use the past tense when they're talking about the pandemic. I did an interview yesterday for London Broadcasting, and I heard a senior parliamentarian saying the pandemic was, using the past tense. And I said to the interviewer, I think that that's a mistake. The pandemic is still with us. The virus is still circulating. There are possibly 10 to 12 million people getting newly infected each week. There are at least 8,400 fatalities associated with COVID each week. So it's still very much present. What have the numbers been doing around the world? Well, if you trust the figures that we've got, then the numbers of people with COVID has actually been increasing in the last week in the Americas and in East Asia and the Pacific. And the numbers of cases have perhaps been reducing in other regions. But we, as I say, can't trust it fully. All we need to be able to say to each other is that there's still a lot of COVID around. Now, fortunately, the virus in its current form, which is causing all the trouble, Omicron and variants of Omicron, the virus does not kill people who have been immunized in the main. It could cause a nasty disease, but basically you're pretty well protected if you're recently immunized. And that's why it makes an awful lot of sense to keep your vaccination status up to date, just in case you're one of the unlucky ones who's going to get severely ill. There are still, I think, a lot of uncertainties in the public's minds about how to deal with the virus at the present time. I've got many people that I know who have experienced COVID infection recently. And many of them have said to me, what should I do? And I say, consult your local authority. And they say, well, I have, but I can't get the information I want. What do you think I should do? I'm still encouraging people who test positively to keep themselves out of the way of others and to really isolate properly, because I still want this virus treated as though it's dangerous. I'm encouraging people to look after themselves when they're infected and to rest and not to try to push against the effect of the virus when they get that COVID exhaustion, but instead to rest and to rest quickly. I'm asking people who are infected to also take care, because there are instances of long COVID associated with increased clotting. And I'm saying, you know, if you're on statins and other treatment to try to prevent you having a heart attack, you should continue to take it, and you should take it rigorously, because there is just some evidence that these kinds of treatments do reduce the risks of long COVID and other sequelae. And in summary, virus is still here, still causing surges, and it's highly desirable that people are protected if they possibly can be, and that they do whatever they can to prevent spreading the disease also if they possibly can. I thought I would now go around the world a bit with some observation on what's happening. Perhaps the one country that seems to be facing some of the most pronounced challenges is China. So I thought I'd start a bit by talking about what's happening in China. The population of China is approximately 1.4 billion people. And at around this time, 1.5 million people are infected. That's 1 in 1,000 people are infected. The total number of deaths in China so far is relatively small, 5,229. So it's a low infection rate and it's a low death rate in this giant country. Compare with the UK. In the UK, current evidence from the National Office of National Statistics is that 90% of the population has had COVID at least once. And the rates of death is 2,400 per million. Well, that's an awful lot higher than the rate of death in China. In addition, in China, the vaccination rate of the older population, the people who are most at risk of death, is really low. It's about 40% of over 80s have received boosters with vaccines. There are millions who are unvaccinated. So the summary situation for China is that 60% of older people are not vaccinated, and the level of infection is really very, very, very much lower than it is in Western Europe, typically in the UK. And what does that mean? It means that the Chinese population is at high risk as a result of COVID. And that also means that if the government did decide to widely reduce the restrictions that have been put in place on movement to try to reduce the spread of the disease, there could be a very high level of severe illness and death, and the economic impact would be huge, not just for China, but for the world. That's why, as far as I'm concerned, what happens in China is relevant for the globe. And that's why I think it's important that we understand that the situation currently being faced by the Chinese government is particularly complex. I think the best advice that one could give, if I were asked for my advice, would be to do everything possible to ensure that people over 80 are fully immunized and boosted. And if it cannot be done with the mRNA vaccines, at least do it with the Chinese vaccines, which are thought to give a reasonable level of protection. So it's not an unwise thing to do. You've got to remember that in 2021, a number of governments made the policy decision to increase their reliance on vaccination to reduce sickness and death as a result of this disease. And those included countries that are thought to have been pretty successful: New Zealand, South Korea, Japan, Denmark, and so on. And if we look at the WHO advice during 2021, it was very strong. You vaccinate and you use public health and social measures as well. So the Chinese challenge is to try to get that vaccination rate up. But what I'm hearing is that because there's been so much emphasis on zero COVID in China, that there's a bit of a reluctance among older people to get themselves vaccinated. It's not an easy thing to do, to have that particular policy reversal. So I just wanted to say this, because I know that there's a lot of writing in the UK press and in the European and North American press about COVID in China. I've got at least one interview coming up on that subject. And so I've been trying to just get ahead of this and to work out what's going on. I've been advised in this by the epidemiologist, Professor Devi Sridhar at Edinburgh, who's been particularly clear on the need to understand the big difference in the epidemiology of the disease in China and in Western Europe. I thought I'd just go to one or two other places and just expose how challenging this is. You see, China is experiencing protests. I don't know whether they class as mass protests about COVID restrictions, for example, in Guangzhou. And there has been some quite rapid shifts in policy. I would just say be careful for the reasons I've just stated. There was a sort of odd thing, an open letter questioning the zero COVID policies in China, asking whether the Chinese are on the same planet, has been circulating on WeChat in relation to the World Cup in Qatar. The language says, is China on the same planet as Qatar, given that Chinese people are seeing a lot of unmasked people coming together at the World Cup? So there's a fair amount of material on Weibo and WeChat about the Chinese policy. All I'm just saying is, I don't think the policy choices for the Chinese authorities are at all easy. I want to continue leveling with governments everywhere on the current COVID situation. My language is this: there are still many mutants appearing, and there's quite a lot of work looking at new variants around the world. It would be really foolish for any government to assume that they are unlikely to be having to experience new variants. So I'm saying, keep your surveillance up, keep looking to see what the viral ecosystem looks like, and keep preparing for further surges by communicating honestly and humbly with people using authentic methods. And also make sure that you build interconnected systems in society that will enable, if there is a surge, the rapid identification of people with disease, as well as their isolation and their support. Those basic principles of detect, isolate, contact trace, and quarantine those who are contacts still applies, whichever variant you're dealing with. And people should be prepared for the possibility they're going to have to do this. We've got absolutely no evidence that the virus is just going to disappear humbly and not go on troubling us. And so keep your masks, don't throw them away. You may have to get them out again for use in confined spaces or in public transport or in schools. Make certain that you continue to practice physical distancing when you know that there's a lot of virus around. And keep remembering that if people are older and if they're at risk because of age or because of diabetes or other diseases, that they do need to be shielded. Make certain their vaccinations are up to date. Always have your strategy in your back pocket and adapt it to the context. And make certain that leaders, as far as possible, are enabled to continue talking about this. Recently in India, I was very conscious of just how much grief there is among those I met with, especially people who've lost younger relatives in the 30s and 40s because of what happened during the second big surge. There is still, in many societies, a lot of anxiety, upset, and concern about what COVID has done to families, what COVID has done to friends. And we've got to remember that the world has not gone through a full grieving process because of the damage done by this pandemic. So continue to be very gentle with people. There's a lot of soreness about. And remember that long COVID is very much there. That I just read the report of the chief medical officer, what is called the technical report. Actually, it's from all the chief medical officers in the UK on the UK situation. It's full of recommendations for subsequent chief medical officers. It's in the public domain. Mahika found it for me. And it's a really very, very interesting report. I read it before giving evidence to the independent SAGE group earlier this afternoon. I think it's an important read. I'll ask Mahika, if she can, to put the URL for this technical report into the chat. I really like it because of the care that the writers have done to leave messages for subsequent chief medical officers on what has to be taken into account as this pandemic continues and what needs to be put into place in case there are future pandemics that come along. And one of the points they come up with is the absolute need to pay attention to long COVID and not to underestimate it, to train health personnel so that they can deal with long COVID, and to recognize how long COVID is a syndrome. It's a mix of different conditions, and that we still believe fundamentally that one of the major causes is the propensity of blood, to clot because of damage to endothelial cells, to form microclots that then block little arterioles that can be in the heart, or can be in the brain, or can be in the lungs. But whatever happens, it's these microclots that are thought to be contributing to some of the symptoms associated with long COVID and post-COVID. So the long COVID, post-COVID challenge is very strong. And several of you have been writing to me during the intervals between these open online briefings saying, do you think we're just going to be getting more and more long COVID because of people getting infected more and more times, and each time they're infected, they are likely to increase the risk of long COVID? I say I'm not sure. I'm still not sure who's likely to get long COVID. I'm still not sure whether their risk of long COVID is proportional to the number of times they get infected. But I'm pretty certain that there will be a cumulative increase in the numbers with long COVID in any community, and that needs to be taken seriously. I can't, in all conscience, be happy with the notion that there are millions of people in countries in the Northern Hemisphere particularly, who are just getting COVID again and again, and this is somehow an okay situation. I think that we need to be very, very clear that every time you get COVID, there's a chance you might get long COVID. And if you get long COVID, there's a chance that you might have long-term sequelae like heart attacks and so on. And so it doesn't surprise me to read the Chief Medical Officer also saying in his technical report published yesterday in the UK that there is likely to be a significant increase in the number of people getting heart attacks and other similar effects, partly because they've got long COVID and partly because the health services are just very badly affected by a whole series of challenges over the last few months, and this doesn't look as though it's going to get any better. So it's in summary, it's not a good situation. We are still experiencing COVID. COVID is still causing long COVID and its sequelae. And just in case you'd forgotten, this is very much a condition that comes and affects poorer people much more profoundly than it does richer people. And so if you are poorer, and particularly if you are less easily able to take time off because you're on daily wages or some other such thing, and you have very limited social protection, then it's much harder for you to look after yourself. It's much harder for you to take care of yourself when you get your COVID. And so I want everybody to remember that as well as the long COVID problem, there's also the inequity challenge. Now, having said all this, what would I like to share with you as one or two of the other things that we've picked up recently? Well, there's a very interesting South African study. It's a lab study using COVID-19 samples from an immunosuppressed individual that were taken over a 6-month period that shows that the virus evolved inside this immunosuppressed person to become more pathogenic, i.e. nastier. And this is just some suggestion that perhaps new variants can still emerge that cause more illness than the current predominant Omicron strain. The reason why I'm telling you this is that the hypothesis around has been that over time, as there is evolution of the virus, it becomes less potent, it becomes milder. Well, the suggestion is that from South Africa that may not be the case, particularly in immunosuppressed people. In the United Kingdom, there is a report that public health leaders were slow to act over warnings at the end of 2020 that people were not having contact tracing and isolation triggered immediately after a positive lateral flow test. It's not clear to me quite what that kind of evidence is going to do, but it's all preparing for the COVID inquiry going on in the UK. But it's that sort of system breakdown that does make dealing with an infectious disease pretty unsatisfactory. There has to be a very clear procedure that when people have got a positive lateral flow test, they should isolate. In fact, they ideally should be isolating as soon as they've got symptoms that suggest they're not well, even before they do their tests. Hanging around and disregarding test results may mean that people are infectious and traveling and moving around while they're infectious. And those of us who've got our COVID may recognize that actually we're often infected by individuals when they're just going into being unwell, and that means that we should take notice of what happens to us if we're in contact with people often before they've got severe symptoms. I wanted to stress that in the UK as well, Dame Kate Bingham, who spearheaded the UK's vaccination discovery program in 2020, has gone in public saying that the UK needs to do more to develop its own national vaccine manufacturing capacity. And she's called out very strongly, some say quite bitterly, in evidence given yesterday to House of Commons Select Committee, that she's saying you did so well in the UK to get vaccine preparations and production in place during 2020, but you've not managed to continue that. And she's saying to the UK government that this is not a wise plan, that a country like the UK, economy number 6 in the world today, she's saying ought to have its own vaccine manufacturing capacity, not just for cell-based vaccines, but also for mRNA vaccines as well. There are some studies in Nature Communications, suggesting that actually persistent symptoms after COVID may be more likely to occur among those who, when people are teenagers, if they come from poorer households or if they got chronic conditions like asthma. We need more of these kinds of studies to help explain what are the determinants of long COVID. It's very good that we have some brilliant long COVID people here who are going to be able to help us. Well, colleagues, that's my brief update on what's going on. I would like to go now to Catherine for any comment, please, from you, Catherine, on who's on and who you would like us to come to quickly. And I am planning, just so that you know, to go very early on to Gregory Hartle from the WHO, because we know that Dr. Tedros has just been doing a press conference, and I believe he was covering some of the issues around COVID in China. And I'd like to ask Gregory whether he agrees with the general positioning that I've done at the beginning and whether he's got any comments. But Catherine, that's so you know who I'm going to come to. Any other suggestion you'd like to give us?
Sorry, apologies. I do have suggestions for who you should speak to, but just a couple of thoughts quickly. David, one of the themes you've been touching on this week is the sort of tragedy of the COVID response systems being dismantled in many places. And I think that one of the things we should be mindful of is that the kinds of public health capacities that we use to respond to COVID are the same kinds of capacities that we would respond to any outbreak, and to dismantle them is an incredible shame. So I think just to throw that out there as a piece of thought for everybody. The next is that by doing this dismantling, we ignore all of the lessons that have been learned about this being a systems issue. This is not a health issue. This is a economic, a political, a health, like agricultural, it's an everything issue. And to pretend like having contact tracers is the only thing that we need is to me a little bit crazy. And I look back at the recommendations that were made after SARS, after H1N1, after Ebola, and now after COVID, and they are the same. And we are not listening. So it would be great if we were all able to listen more. And by we, I mean countries, and by countries, I mean leaders. And so probably not we, because I am not included in that list, but still. The next piece is just to let everybody know that WHO is supporting a all-country process of negotiating a new international instrument, as we've mentioned before, and the next international intergovernmental negotiating body is happening next week. So, and there is a zero draft of an instrument online. I'd be happy to send that link through our chat to everybody so you can see it. So progress is being made in this kind of longer term preparedness. So that's my updates, but just to mention that Claire Rayner and Ray and Sammy have a couple of really interesting pieces that you might want to go to. And I know there are some longtime folks here that we haven't heard from. That would be great. I have sent you a list in our WhatsApp chat. We have Jane Badham here. We have Rebecca Cantor, Gower, and unfortunately Iman had to leave because she had another conflict, but I will leave it to you. This is a rich group. So back to you, David. Oh, and just to remind everybody, I know it's in our chat, but please do let us know if there's anything you don't want to show up in the public record.
Very good indeed. So I'm proposing at your suggestion the following list. I'd like Mahika to come in briefly in case you've got any messages for everybody. And then I'd like to go to Claire Rayner, Jane Badham, Goaha Atif, and then Rebecca Cantor, Karen Palmer, and Zara, if you would like to speak, that would be very nice. And then anybody else, could you either put up your electronic hand or write in the chat or just wave at me, anything you'd like. I see one or two people looking, but actually, before you speak, Mahika, let me just go to Gregory Hartle now, and then so it'll be Gregory Hartle, Mahika, Claire Rayner. Gregory, please.
David, thank you very much. I've already seen 3 points that I want to comment on, 3 different issues. Certainly to echo what you were saying earlier about China, to come to that first. The Director General, I think we have to make 2 points that one, every country will make their own decisions and adapt their own strategy in light of the local context. But every country also needs to remember that policies need to be agile and adapted to both the epidemiological and socioeconomic context, and then to be able to adapt its policies in view of the changing characteristics of the virus and the availability of tools to limit infections, save lives, etc. And that comes to the second point that seemed to be particularly evident in the case of China, which you also mentioned, is that vaccination rates, especially among the elderly, are very low. I'm going to check just for a second, and it is, I believe, only 66% or two-thirds of people over 80 in China have received even their primary series of vaccines. And when you go to the boosters, it's down to 40%, figure that you mentioned, David. So it's very low. And I think given what we know today, which you also mentioned, that being properly vaccinated is an extremely strong protection against severe disease and death, that this is really something which makes a lot of sense to pursue. So we would like to see that. And that's also why WHO pushes so strongly to try to get to the 70% mark of the general population and to the 100% mark of vulnerable populations. Yeah. So on the second matter, just to say that with the treaty negotiation process, or it's called a pandemic accord, it is being addressed extremely carefully and methodically, trying to take into account the differences of all the different countries looking at this. And what's happening actually on Monday through Wednesday is the discussion of what's is called a conceptual zero draft. They're not even yet at the zero draft stage. And they have to basically, between now and the fourth meeting of the Bureau of the Intergovernmental Negotiating Body in February, agree on moving from a conceptual zero draft to an actual zero draft, which then can be the basis of negotiation.
So that's pre-negotiation almost, really?
Correct. That's exactly what it is. Yeah. Negotiation, if and when hopefully it begins, would only begin after the fourth INB in February.
Wow.
And
that's INB, everybody, is Intergovernmental Negotiating Body or something. Is that right?
Exactly. Yeah. That's right. Sorry. And then just to respond to something that Rebecca said about Twitter, and yes, the fact they're apparently going to stop how would you curating content on Twitter. WHO is basically, its lines on that are important, and what we're saying is yes, COVID-19 misinformation remains a threat as it was before the pandemic and during it, and as the pandemic continues, and we call on all social media and tech platforms to continue to adapt their policies against dangerous information misinformation across the health spectrum.
Yeah.
So anyway, it's one of the infodemic has been one of the biggest.
You call it the infodemic, don't you? Misinformation. Yes. You've got, and you spotted it early on. I remember Sylvie Briand and others said this is going to be a real problem, but it's become absolutely massive, and it's really restraining good public health action, because public health people hate receiving horrible death threats and so on their social media and email, and they more and more I meet people who are just feeling fed up and they want to disengage. Are you finding that, Gregory?
Yes, I mean, we hear a lot of stories from the people who have been in the front line during the pandemic about numerous threats again and again and again. And Mike Ryan, for example, was told by relatives at one point that he had in the US, don't come to the US, because he was so notorious, inverted commas, because there's such a strong, as we know, anti-vaccine conspiracy community there. So it is something which has affected a lot of people in WHO and in public health generally. We've heard again and again about how people have had to change their lives completely just because they're trying to promote good and proper science and measured reactions to the pandemic threat. It's insane.
Yeah. Well, it feels insane when you think back to where we were in 2019 even, but it's the reality, isn't it? And I'm sure there are many people on this call who are conscious about just the amount of vitriol and anger there is against those of us who are working for public good and public health.
Yeah.
Yep. Thank you, Gregory. Gregory is absolutely brilliant to me in my work as a WHO envoy. He keeps me informed and he connects me to the insides of WHO. Let's go to Mahika Acharya. Thank you for joining us, Mahika.
Hi, David. Thanks. I just wanted to mention that the discussions that we have here at the open online briefings always contribute to how David positions himself in media interviews and any advice that he may be asked to give by governments, academics, and academic and research institutions afterwards. So this really helps. And whatever material that you provide, the stories that you give about how COVID has affected you personally, where you are, the stories and information and questions as well that you submit in the chats help, and they really matter and make a difference. And on that note, I also wanted to mention that Claire Taylor has some slides that she would like to share on reinfection. So I'm not sure where you're going, but this is just to let you know.
Thank you very much indeed. I would like now to go into a sequence of comments and inputs around either reinfection or long COVID or both. And so that means I want to go to Claire Taylor, then Claire Rayner, and anybody else here who wishes to talk about long COVID. Just to say that as well as hearing briefly from some of those I mentioned just now, I am going to ask Twee as we reach towards 6:30, and I'll make sure there is time to give her thoughts about the next series, and I'm going to ask Annie Feltham to comment as well. That'll probably take us through to the end, but I'm not going to be rough about the end, and if there are still others who wish to speak, please use the hand raise function to make yourself present and to say that you wish to contribute. Claire Taylor, please.
Hi everyone. For anyone that doesn't know who I am a doctor in Scotland and I run a long COVID clinic. So I see long COVID week in, week out, and these are real people. So I wanted to share a slide.
Yes, please.
I shall attempt to do that.
Thank you.
To share,
just while you're doing it, I think we feel here that you doctors working with those who've got long COVID are really very, very important people. We're honoured that you spare the time to come and join us. So over to you. You're with a group who really value and respect you, Claire.
Thank you very much, David. It's not an easy job, but it's even less easy for the patients. So I'll try and keep this quick. It's just a few things to highlight as we go forwards with our plan of living with COVID. So I wanted to draw attention to the study looking at reinfections, the US veteran study, and they started with 500,000 people, and then they put them into groups of no infections, 1 infection, 2 infections, 3 or more infections. So they had 2 outcomes. One was the hazard ratio and one was the excess burden per 1,000 persons. So for anyone that doesn't know the hazard ratio here, 1 means there's no difference, and then over 1, that's worse in this case, and less than 1 is better. So unsurprisingly, it's not better if you get COVID. And green is 1 infection, orange is 2 infections, and purple, bluey color is 3 infections. So you can see with the hazard ratio that the 1 infections are all down here, just a little bit, off from the neutral line. And then look how far out the 3 or more infections are. We're up about 8 here. And that means, so if a hazard ratio is 2, it means you've got double the risk, basically. So we've got this hugely increased risk of not only hospitalization, but cardiovascular disease, coagulation. I presume that means clotting. David talked about microclotting, diabetes, fatigue. I mean, every part of the multi-system. And I've seen it presented in another way, which was the main thing I wanted to share. So I don't know if those lines keep going up. So that's 3 hospitalizations very steeply up there. and everything else is going up. And you know, I've already had at least 3 infections this year, possibly 4. I'll tie into that in a second.
This year, this year.
I had an
Wow.
infection. I had March, June, and August, all confirmed
Wow.
infections, possibly January as well, within, I think, from my workplace, which is what I'll go into in a second. I am recovered. But yeah, it wasn't very nice. And so I suppose the concern is that we got up to 3 in this study. They followed up for 6 months and then I think up to a year. Every study always finds up to the point they studied, the risk is still there. So where now some studies are saying, oh, well, the risk is at 3 years or 6 months, or it seems to be that the risk just keeps going. And I personally think it ties into the vascular inflammation. And Dr. Duncan talked about that really well before. And then I wanted to go on from that to talk about the study that came out and caused a bit of a stir this week on masks. So it was looking at N95, which are the really cool looking ones, I suppose, you know, that fit around your face and that they've got filters, etc. And then you've got the medical masks, which are like the blue ones that you often see people wearing, and they don't really fit around and create a seal or anything. And this was to look at, you know, where healthcare workers are more protected with an N95, which you would assume would, without even doing a study, would be the case. And there's been a lot of talk about PPE in the pandemic and protecting your healthcare workers. And so there was a lot of headlines this week that they're the same, that it didn't help. And I think a lot of people that know about COVID and masks thought this doesn't make any sense at all. So I just wanted to go to the limitations of the study. I'm not going to go into it too much with the time, but these people could switch between masks. They could leave work and then go out to the shops without a mask on. To let that sink in. This is a study, a really important study on protecting healthcare workers around the world. And people could go to the shops or mix with their friends with no mask on, and then conclude that they're not any better. So, you know, I think we have to be a little bit careful about headlines, but also what studies we do and how we do them, because this is real people, it's real people's lives. And if you do a study and you conclude these things, and yes, they've put limitations in, fine, that's not what makes the headlines. That's not what influences policy. So there was a little bit about that. And then the other one thing was just to talk, sort of leading in from there, about the risk of groups. You talked about who can get long COVID, and, you know, looking at those reinfection graphs, that is long COVID. That's long COVID. You know, you get to 6 months, you've had, you know, you've not got better, you've been in a hospital, you've got a clot, you've got fatigue, that is long COVID. Now, you look at the masking, there still isn't N95 masking in the UK and a lot of countries. And then if you look at the ONS government data on who's more likely to get long COVID, you've got these groups encircled here: healthcare, social care, teaching and education. 3 massive sectors where the risk of long COVID is higher. If that's because they're getting more reinfections and they're not properly protected, we could end up with a situation where some of our most needed skilled workers are taken out with long COVID. And I'm seeing, you know, in my clinic, anyone seems to be able to get it. There doesn't seem to be a particular one risk factor, but I just wanted to highlight, to pull all that together, that going forward, I think protection is a big part of living with COVID, and also getting treatments for these things, because there's no point in a study saying X% get fatigue, X% get this. We need to start treating it. We've got enough people now that are damaged with long COVID. So that's my
Can I just say, you know, here I was at the beginning of this discussion saying, I still don't know whether you're more likely to get nasty consequences if you have several reinfections. And look what's happened. The amazing Dr. Claire Taylor has dug into her stock of slides and has put some slides up here that at least go some way towards answering the question. Yes, David, if you have several reinfections, your risk of bad stuff happening is greater.
I didn't actually know you were going to say that, and I actually have put them, but I had put them together.
Wow, even better, even better. anticipated without talking. But
So I'll
let's
just take this down and get to somebody else. Thank you so much for letting me do that.
But listen, everybody, we are blessed that we are joined by these doctors who are working on this issue. They are right at the front end of the thinking about this. They're right at the front end of the science. As a result of coming and joining us, we've been able to connect them with Maria Van Kakova, and that's important. And I think that they are not going to give up. They're going to keep telling us that there is something very serious going on here. I was going to go to Claire Rayner, and then I am going to go to Ray Duncan. I know that it does mean that those of you who are waiting to speak have to wait a little bit longer, but I wanted to, all those who might want to say a word about long COVID to have a chance to do so. Claire Rayner, please.
Hi, thank you very much. I'll try to be brief, and I probably read off some points just to sort of get my back. It is amazing because I was pulling together my thoughts before and during this, and some of the things that I was going to say have come up. There's something incredibly fortuitous about that. I want to say that I agree we should move forward to thinking about these interconnected systems, about food and what we produce in the world, and COVID. I went out to buy some computer paper this week to the retail park. I went around 4 huge shops and I could not buy a pad of paper. But what I was faced with in all these shops was row upon row of tacky stuff for Christmas, plasticky silver, row upon row. And I just thought, why are we doing this now? Why are we doing this? That's one thing. The workplace study that Claire mentions, I'm just going to say outright, utterly, utterly unethical. My question is, why was it not conducted with people who knew about public health, occupational and environmental health? So I'm raising that question. This is still a category 3 out of 4 hazard group virus, certainly in UK and US classifications. It's still a notifiable disease in the UK. I think we're headed for a lot more grief in the world. As you said, be gentle with people. Unless we really get on top of this, we are going to, I fear for the grief and things that people are going to face and feel. I'm interested in trying to speak truth as far as anybody can know it. I want the historians and writers amongst us to make a record of things that we are doing here. We're very, very worried with the amount of disinformation that's going on. And thank you, Gregory, for being here. We're bewildered. I am a clear thinking, articulate person. And I'll speak for myself and say this is the most difficult situation, being surrounded by misinformation and disinformation and trying to sift through what's real. This is a real problem, and this is aided and abetted by some senior influential doctors around the world. Medical students, I was discussing with my colleagues this week, they mask, it's now voluntary now, I teach them. We've described 5 incidents where medical students had coughed in our faces. We'd asked them to get masks on and they refused. And I said, you will get a mask on now or you go home. You know, this is almost as bad as giving somebody a deliberate needle stick injury. We got to get the culture better. Finally, I want to mention about schools. So in terms of, or in the interest of truth seeking, I want to ask questions. Where are the public health authorities that we used to have who were making these, who used to keep schools safe? Who is making the guidance now, and are they public health trained? And why are parents being prosecuted for not sending their ill children to school? So thank you for hearing me. That's really just.
Where's the prosecutions happening? Have you got, are we talking about England, Wales, Scotland, Northern Ireland, or are the prosecutions more localized?
Sammy, do you know the answer to that, Sammy McFarland?
Hi, I do, in terms of the experiences I'm seeing in the group, and it's very much the UK, but also the USA, Canada, Canada as well. and other countries, European countries, are contacting us saying the same thing. And I mean, just yesterday I was in a child protection hearing where a parent was being told their child was going to be removed because their child hadn't recovered at the rate the doctor thought that they should recover, and because the child was using a wheelchair, because she didn't have the ability to walk, they thought that the child was being kept sick and it was fabricated illness. And it's absolutely harrowing to be involved in these cases.
Thank you, Sammy. We're going to go on with this sequence. Ray Duncan, please. Thank you for joining despite all the problems you had with the access. Ray Duncan, cardiologist from Newcastle.
Thank you. Can you hear me okay?
Yeah, perfect.
I have to apologize. I'm late and I'm trying to run this off my phone. I did have some slides, but I'm having some technical issues, so I'm going to have to do it off my phone instead. I wanted to come on and just basically say a little bit more about things that both Sammy and Claire have touched on, and I want to talk about children today. So at the beginning of the pandemic, before we really knew what this was, we were told initially kids don't get COVID, we don't need to worry. We now know as time's gone on that that's not the case. Then we were told kids don't transmit. We now know that that's not the case. Then we were told kids don't get sick with COVID, and we now know that they do, and they can get both PIMS, TS and long COVID. And over the course of the pandemic, there have been 100,000 children sick with long COVID in the United Kingdom, some unable to go to school, some wheelchair bound. But other things that we also now know that there is evidence that COVID is causing subclinical organ damage in our children. And we know that from a small biomechanistic study in Germany, looking at the lungs of, this is not just kids with long COVID, this is children who've been infected with COVID, had a mild infection and clinically have recovered, have subclinical organ damage in their lungs. We also know from other studies that there is an increased incidence of diabetes developing that we're seeing in children who've been infected with SARS-CoV-2. We now know that COVID is causing endothelial damage in adults, and we suspect from some very early evidence that it may be doing the same in children. We don't have all that data yet, and we definitely need to investigate that, but it's something that we absolutely need to study, and we need to study it because we know that endothelial damage is the precursor for the development of atherosclerosis, heart attack and stroke. We also know, as Claire's very clearly said, Claire Taylor, that repeat COVID infections increase your risk of all of the above. Now, the study she was referring to was in adults, but Sammy McFarland and her amazing team at Long COVID Kids have done a kids reinfection survey, and we're also seeing that those risks of long COVID are present in children who get reinfected too. So with all that in mind, I wanted to just share something slightly personal that happened to my family in the last 3 weeks. So I have 4 children. My oldest 2 are at high school. None of my kids have long COVID, thankfully, yet. But one of my children has had previous COVID-induced cardiovascular complications. My older 2 tested positive for COVID again 3 weeks ago. So I rang the school to inform them the kids had COVID and that they'd be off sick, and asked if they could have some work sent home for them to do while they were convalescing. And I received a message on my voicemail the following day from the school attendance officer telling me that there was no need to keep them off sick while they were still testing positive and infectious, and that after 3 days I was to send them back to school whilst infectious, which is obviously potentially going to spread to other children. And this is apparently now public health policy in the United Kingdom for kids in schools. So I guess my question really is what I wanted to ask is, what are we currently doing to protect our children from a CDC level 3 biohazard while we try to figure out how bad the organ damage is going to be and what their future health going into adulthood is going to look like? And the answer that I've been able to come up with so far is actually very little. So in the United Kingdom, we have recently taken away routine vaccination for 5 to 11-year-olds. We've taken away masking in schools. We've taken away social distancing. The children are not in classroom groups anymore. They're moving around classrooms. There's no air filtration systems being put in place. And we now have a health policy that is advocating and ringing parents, telling them to send their children back to school while still infectious with a level 3 biohazard that can cause organ damage. And I have seen what this virus can do to people. You know, I'm researching it, you know, I'm looking after people with it. So I try and do everything I can to protect my children. And when they're with me, we mask and we have HEPA filters. But then I hand over my kids to the safeguarding of the school system. And I expect them to be kept safe at school, and they're not being kept safe. This is their third infection now. And one of the things I wanted to say is that our kids have got no choice in all of this. They cannot advocate for themselves, and it is our duty to protect them. Our children should not have to choose between their health and their education. So the question really is, what should we be doing about this going forward? And so I'd just like to touch on a big report that was published by our Chief Medical Officer and the Chief Medical Officers from around the UK, including Frank Atherton, just yesterday. And I don't know if Frank's on the call, but if he is, I just wanted to say thank you, Frank, because there is a section in this report that I have read, and I was going to try and read it off my phone, but I can't because I'm talking to my phone. But the gist of it is, under schools, it talks about HEPA filtration. And it says, and I quote some of it, so far there's observed reduction in risk, which is modest. There's a widely reported study from Italy suggesting ventilation in schools could reduce the transmission of COVID-19 in schools by over 80%. Now, that paper has not yet been peer reviewed, but there are other papers coming out of Denmark, Belgium, and Holland suggesting air filtration in schools can reduce the risk of COVID 12-fold. So I wanted just to talk about that for a second, because HEPA filters and air filtration systems in schools do not negatively impact on a child's social or psychological development, mental health, or well-being, but they have already been shown to reduce COVID outbreaks. And actually, air filtration systems in schools might improve both the health and the education of our kids going forwards, because it may result in better school attendance because of less sickness absence. So I guess one of the other things I just wanted to say is I think we need to remember that we're living through a SARS viral pandemic. We are living history. Every decision that we take or do not take today to mitigate the spread of this virus, which we know if you get reinfected gets substantially worse health outcomes, every decision that we take as individuals, as societies, as national leaders, and as world leaders is going to have a global repercussions for both the health and the economic burden of nations for decades to come. Every decision that we make or do not make now to protect the current and future global health of our citizens is going to be studied in the history books for decades to come. And if we continue to fail to attempt to reduce the reinfection risks from this virus, knowing that they're there, there's published data to prove it now, knowing the potential impact this is going to have on our global and economic future health, then I fear that we are all going to be on the wrong side of history. And I hope our children will forgive us. So I guess what I really want to say is quite simple, really.
Yeah.
And it's to our world leaders. And I want to say, please invest in clean air.
Yeah.
Please invest in public health,
Yeah.
the public health of your citizens. Please invest in the future health of your children. And please invest in the future economic prosperity of our nations by taking measures now to reduce the current and future health burdens of our citizens from the long-term consequences of repeated SARS-CoV-2 infections. And that's what I wanted to say.
Beautiful. Thank you very much indeed. I think everybody here is just massively grateful to you for coming on, for speaking what you're feeling. I think we are, many of us, totally convinced by what you're saying. And I think we feel that we need to use whatever avenues we can to make the point that there is a real likelihood of increased risks for children being visited on them as a result of some policies that are around at the moment. in the UK. Thank you. We keep going. Just Rebecca Cantor, if you wanted to speak, you have a moment now, and then Karen Palmer.
Yeah, thank you everyone for sharing. I'm gonna switch gears, going back to vaccination, because, and I'll just speak from my experience here in Chile. So everyone here now has to have either 4 or 5 vaccines, and then they're recommending annual vaccines. But we also know that the fidelity of these vaccines wears off over time. And we haven't even begun to discuss that even in this group. What happens in these years to come if we even stop vaccinating where we were vaccinating before? And Gregory mentioned that every country needs its own rules, its own plan, which I kind of get it, but that doesn't, it sort of goes back to the whole idea of the COVAX. That doesn't address the inequalities in vaccine rates and vaccine access in the world. And then to tie it into my own personal experience. So tomorrow I'm supposed to leave to go to Japan. To go to Japan now, you need either 3 vaccinations or a negative COVID test. But my 3rd vaccination, which was really my 5th, since I can't get my 3 Chilean vaccinations and my 2 American vaccinations on the one thing, was in February. So I don't know, even though it's my 5th vaccine, I don't know how much immunity I have from that at this point going to Japan. And then when I went to upload my vaccine certificate to online, it said it's not in a language that Japan accepts, even though it is in Spanish and English. Yeah. So just in case, I went to get a negative COVID test, which is the alternative. But then that had me think, well, people who are positive for COVID can still enter into Japan or any other country if they have their vaccine certificate, and many countries are even just asking for 2 doses of the vaccine, not 3 like Japan. And so I just want to throw that out there to the group of what's even going to happen with all of us who have been vaccinated but don't continue to vaccinate or even test one way or the other. Thanks.
So there are enormous inconsistencies. Thank you so much for making this point.
Yeah, and we need a global, global way to track even vaccine.
Yeah, and this is where having Gregory here is so important. And also, I am going to follow up with Tedros on these issues, because I actually think that the level of inconsistency is just too great, and it's too easy for people to be mistreated because of this. Thank you very much indeed. I want to go just asking very short comments now to Karen Palmer, please. Karen, are you there?
Thank you so much, David.
Yeah,
I feel like every time Ray Duncan speaks, we need to have a moment of silence. Like Dr. Duncan, what you say sits with me for weeks afterwards, like it doesn't leave. So I have been working on a draft of a report on pandemic communications. I've done 11 hours of key informant interviews with scholars in communications. And I just want to read you 4 summary statements that I've composed. This report is not published yet. It's not yet approved for publication, but I think it's important. So this summary statement number 1 is that the infodemic, back to Gregory Hartel's point, was enabled by a lack of transparency, polarization of science communications, failure to effectively communicate uncertainty, and lack of timely official communications that created an information void filled by conspiratorial messages. The next is that conspiracy theorists gained traction through simple, persuasive language that offered certainty where none existed. The next is that communication strategies that can help combat the infodemic include providing better information, social listening to expose and preemptively counter misinformation, appeals to hope rather than fear alone, and radical transparency to build trust. And the last is that public science communications is a team sport, yet there appears to have been insufficient consultation between governments and communication scholars and practitioners whose expertise might have helped reconcile the tension between medical ethics and public health ethics that resulted in conflicting messaging. So I leave you with those thoughts. I hope that we can soon publish this report, and I'll happily share it with you.
Well, can you share it before you publish it? It's just so important.
I know, I'm trying, believe me.
Okay,
Yes.
with no pressure, no pressure.
I want to. Yeah.
I'm just to orders because I know we're terribly late. I want to hear from Twee. She is our in-house communications specialist who's been behind this work at the beginning. I want to go to Annie Feltham and then to Florence Egal. Then I promise you we will come to a late end. I apologize for that. Twee, please.
Hi, everyone. So I just wanted to reflect on this journey that we've been on briefly, and then talk about next year. And from a slightly different angle, I'll describe it in this way. We've certainly sailed through the rough seas of the COVID pandemic together. Nearly 3 years ago, we started with a formidable captain helping us navigate this all. We were guided, our compass was always clear: people, public health, and focusing on different places where this is important. We've traded knowledge and made some amazing connections, which has left us with some beautiful collections. We have COVID-ready video clips, songs by Nazim, podcasts by the Global Goals team, and live illustrations thanks to Chris and his colleagues. We've shown solidarity with those who have lost and shared their stories with us, and the struggles we continue to hear even in the session today. But we've also had some joyful moments. Certainly there have been, and we do hear continually, that there are troublemakers, there's trouble in the seas. We've seen big and small waves, and we don't know how much more there is to come. But I hope these open online briefings have helped you, either individually or collectively with us, feel more COVID ready to navigate what comes next. What we would call, we hope that you've made sense, we've helped you make sense of what is going on by respecting the complexity of the living systems in which we live. And so for 2023, with Mahika and David and Catherine and John and the rest of the team, we're not sure where we will go, similar to how this journey started, but we know that we keep the same values at heart. And I'm sure that to keep an eye on your inboxes, you will hear from us. We would like to hear from you about where we can take this group together.
Twee, we're blessed to be with you. You've managed somehow, because I only asked you to prepare earlier today, and you've done it super fast. Thank you for that. And it's really very powerful what you've managed to say. You and Karen, Ray, and others have just made such strong contributions. Let's go to Annie Feltham.
Thank you. Thanks, Twee. You summed it up fantastically. I've been on these briefings now for 2.5 years, and I think we've learned a lot from each other. But also, I just want to thank people who've been here that long, because during lockdown, this was a real lifeline for me and it's sort of a window on the world. I'm very pro this idea of bringing in this wider context that we're working with. And so I completely agree with Catherine when she said that COVID was a bit of everything. You know, it's not just public health, it's housing, it's poverty, it's inequality. And before we get too sort of pious about rich countries, we've got people in the UK who can't feed themselves. And so we have a real inequality problem here. We've got children who are going hungry to school, and we've got people whose living conditions are so bad that a little boy recently died of damp. And so it's the whole environment. But what I want to add in something extra about than that. We know it's the whole environment, but in addition, the work that I do as a political scientist and the NGO I'm working in, where we're trying to learn from other people's experience, that's really important. So what we've learned from COVID is helping us with the the crises that people are facing now, is that when Ray was in a heartfelt way complaining about how we were treating our children, I can say that actually that tells it's about how we are governed. And there's an awful consistency in the quality of government, whether we're talking about railways or health or education. I could just give you a whole list of things where the quality of governance is just as bad in the NHS as in schools. And some of my friends are teachers and they just blast off because they're so frustrated. So it's all there. And so in a sense, I'm hoping that we can not move away from, that's wrong, because the work that you're doing, Claire, is really important. And those I'm hoping that we can add in this understanding of we're shouting in the dark if we're just asking for better public health, because we're not getting better railways, or we're not doing anything about air pollution, or people are living in dreadful housing. And so we have to work out how to intervene in this whole system where inequality is getting worse, and we're responding to that at a local and a national level. And I got given a great motto the other day, which I hadn't heard. And I just thought, yeah, this is right up my street. And I'll leave you with this. And when we're thinking of how we're going to shake things up, we proceed until apprehended. And I just, we're pushing hard at all sorts of things and breaking down the boundaries. And at some point we will be apprehended, but then we have to find a response to that as well. And so I think my plea for next year, Twee, and I absolutely agree with everything you said and with everything that Ray said, Claire Rayner said it made her cry. Fella cry, made me feel, I don't know, like crying or almost like punching somebody. Is how do we include this wider environment so we act more forcefully and we have better outcomes? Thank you.
Thank you, Annie. Florence Segal, please.
Yes,
Florence.
thank you.
Yeah.
Thank you very much, David. It's hard to talk after Annie's last comment, which of course I think we all live with. I wondered whether it was of interest to this group or not, but I just wanted to share what's happening in Italy now. There is a big crisis. It's all over the media because they have no more pediatricians. And the reason, and of course, all child care in Italy goes through pediatricians, not through family doctors. But what they were saying is that there is now a big surge in influenza and pneumococcus, what do you call it? And COVID, but they say the problem is that now everybody just gets tested for COVID, and if they're negative, then they don't worry about it. And they're really getting concerned because they're apparently winter's just starting. This seems things starts really bad, and they're concerned that given the whole attention to COVID in the last 2 years, people are not going to take seriously the other problems now.
Thank you very much indeed, Florence. Thank you for reminding us that it really is super desirable to look right across all the issues, as Annie just said. Florence has been encouraging us in our work on food to really focus on what happens in territoire, that is in jurisdictions and local authorities that are at the local level. We will do that. Ray Duncan, it is our privilege to give you the absolute last word. We're going to stop. Ray, can you unmute? I can't do it from here.
Sorry. So I was just going to come on to something that Florence had said. There's, I believe, something similar going on in Canada with COVID and flu and RSV, and obviously that's concerning. We don't know if COVID is or is not damaging the immune systems of children in the way it seems to be potentially damaging some T cells in adults. We don't know that yet. But coming back to the preventative stuff, and I know I'm banging on about air filtration again, but air filters would help with all of this. All of these viruses are respiratory spread, and it would help reduce reinfection rates for not just COVID, but other viruses that could potentially make children quite sick. And the last thing I just wanted to say very briefly is a couple of the things that I talked about the association between COVID and certain organ damage in the epidemiological studies. Just before anybody jumps on me, association doesn't prove causation, and we know that. And people may point that out, and that's fine. They would be absolutely right. But that's not the point of this. The point is, if we have a clinical suspicion that's high enough, rather than wait 2 or 3 years until we've investigated this to the nth degree, the precautionary principle applies, and we have to protect our kids.
There you go. Absolutely agreed. Absolutely agreed. Everybody, our work on the worldwide cost of living crisis that we're doing out of 4SD shows us that it's particularly serious in terms of the poverty slide for tens of millions of households in low-income countries, but it's also serious for poor people in middle-income countries and for poor people in high-income countries. We're seeing that somewhere in the region of 15% of households in the US and in Canada and in Western Europe, including the UK, are experiencing extreme levels of poverty. It's not just in poor countries. You're seeing it, we're seeing it, that household members are having to make appalling choices. And those choices have an impact not just on what they eat, but on their health, on their education, on their security, on their shelter, as we just heard, on their transport. They have an all-round impact because this is a really nasty, deep poverty trap, and it's affecting so many. It's a global phenomenon, and you're describing it viewed very much from a UK perspective, some of you, but it's worldwide. And that's what makes it particularly challenging, because it's affecting so many people in so many places. That's what we're working on. We will go on finding space to talk about it, but now, with your agreement, I'd like to stop. I'd like to wish you all a very good end of the year. We'll find a way to reconnect next year, as you've heard. And with that, I thank you very, very much indeed. I'd just like to greet one or two people. I did see one or two, and I just want to give especially, my brother William is here, and I see you exchanging chats. Do you need to say anything about it, or is it okay in the chat, William? I've lost you.
He's there.
You've lost me because I haven't unmuted. No, I'm making an observation which I can't yet articulate properly, and therefore I just leave it, hoping that other people over time will be able to add to what to me is merely at this stage a very disturbing surmise, but it's picking up a point that Nigel Lloyd made.
Okay, there it is. It's in the chat. Starts, I'm convinced that Nigel is correct. Okay, and William is referring to the poly crisis. He sent me an article out of the Financial Times that uses that. I'd like to greet Annie and Keith Appleyard. Annie is my sister. She's
Hello.
also a doctor, and it's lovely that Annie, William, and me are on the same call together. And I would like to just check to see whether my daughter Polly is on with her son Otto. There he is. Lovely to see you, Polly. Lovely to see you, Otto and Isaac. Hello, hello, hello. Everybody, thank you very much. Thanks to our team. As we said, life is about children, and it was very much all of you who brought that up, and that is mattering so much. I look forward to seeing you after the new year. Bye-bye, everybody. Thank you. I don't know, Claire, I don't know when it is. Somebody said, when's the next call? It'll be early in the new year, and we're just trying to work out when we're going to do it. But I think just my hunch is that we'll try and do something perhaps on the 6th of January. And we'll see how we get on. Just that's provisional date. But we've got all sorts of issues to work through in Forest E for next year. And we hope we'll get some of those sorted out by then. To Chris Lara, it's lovely to see you. I send you the warmest wishes to you in the US. Thank you. Richard Longhurst, as always, Marion Hazelgrave. Everybody, thank you very much indeed. Bye.